This is a lecture on critical care haematology. My name is Sam Orde. I'm an ICU doctor at Nepean. Only 1 to 2% of admissions to ICU are for primarily haematological disorders, but we perform full blood counts and coag profiles on every single patient that comes through the door. And in that regard, obviously, these questions regarding haematological issues are asked again and again in the exam. I've split this talk up into the following headings that you can see. I don't think it's an exhaustive approach. I don't think I go through every single haematological problem that's known about in the ICU, but I certainly try and hit the big headings if I can. In terms of things like the blood film, I'll show some of the greatest hits, but as I said, it's by no means exhaustive. Finally, we'll end up with discussing a few haematological disease processes they love talking about in the exams. They may not be the most common things that we see in the ICU, things like TTP or HUS, but they're certainly, you certainly need to know about them, and they're certainly asked in the exam. So let's start with anemia in the critically ill. So anemia is classically defined as hemoglobin less than 120 in females and 130 grams per litre in males. And we'd see that in up to 80% of our patients. But I guess what we're really interested in is hemoglobins less than 90, and we're going to see that up to 50 to 70% of our patients. Of course, multiple factors are going to be at play. Inflammation, blood loss, renal impairment, nutritional deficiencies. We're going to see it all. It's important to consider treatable causes and identify when we need to do more detailed investigation. In terms of the diagnostic approach, obviously history is extremely important, and we need to examine for pre-existing comorbidities such as cardiac or renal involvement, consider medications that may be at play, dietary or nutritional deficiencies, as well as symptoms that are suggestive of blood loss. You need to consider whether the hemoglobin drop has happened acutely or chronically, and in the examination, examine for jaundice, lymphadenopathy, and organomegaly. If you see a low hemoglobin level, it's important to consider if it's an isolated anemia, or are you dealing with a low hemoglobin level associated with other cytopenias, such as thrombocytopenia or indeed pancytopenia. Thrombocytopenia, just like anemia, is seen commonly in the ICU. We see it typically in up to about 40% of patients. And again, it's often multifactorial. It's difficult sometimes to prize out exactly what's causing it. And common causes are going to include both sepsis, organ failure, and acute blood loss. It's important to consider a couple of differentials in that, such as DIC, or disseminated intravascular coagulopathy, or TMAs, or the thrombotic microangiopathies. And in this regard, it's important also to look at the clotting profile and the blood film, which we'll discuss shortly. Pancytopenia, where we're seeing all parts of the full blood count in the low levels. And it's important to obviously consider, make sure you haven't got a dilutional component to this, but it can result from bone marrow disorders, from bone marrow failure or infiltration, infection, hypersplenism, megaloblastic anemia, autoimmune disease, and some of the rarer causes like HLH or hemophagocytic lymphohistiocytosis, which you're often going to be seeing this sort of pancytopenia, but it's associated with a fever. And if the cause of the isolated anemia remains unclear, it's worth classifying it on the basis of mean cell volume. And this is sort of the classic way we talk about it. So we'll start off by looking at the normocytic anemia. So anemia is most commonly normocytic in the critically ill patients, and again, it's usually multifactorial. It can be due to iatrogenic causes like frequent blood sampling or hemodilution. And of course, occult blood loss can occur as a result of GI inflammation or other coag defects. But I guess one of the most important reasons to consider for a secondary anemia that we see is anemia of chronic disease or anemia of inflammation. And this is probably the most common cause of anemia in hospitalized patients. And again, it's multifactorial. And it's multifactorial, being associated with infection, cancer, autoimmune disease, or chronic kidney disease. And this results, I guess, in a functional iron deficiency where adequate iron stores may be present, but the availability of iron for erythropoiesis is reduced. I'll show you a table in a second about some of the iron studies, but typically we're going to be seeing in anemia of chronic disease, the ferritin is going to be elevated and the serum iron and transferrin saturations are going to be low. And even if you provide iron supplementation, it usually makes no improvement. The microcytic anemia is often the result of iron deficiency, which can come from blood loss, malabsorption, or dietary disease. At the extreme end, anemia of chronic disease can cause it, as well as hemoglobinopathies like thalassemia trait. And it's more, and I guess some of the rarer causes in considering hyperthyroid or bone marrow disorders. The blood film typically is going to be useful in this scenario where you're going to see hyperchromic microcytic red cells, polychromasia, and pencil cell poikilocytes, and I'll show you examples of all of those at the end when we start going through the blood film. I guess tests to look at the iron status in critically ill patients are not as informative as they are in sort of outpatient scenarios. And I guess the most reliable measure of iron storage is specially stained bone marrow aspirates, but this isn't normally done in the ICU patients. And typically we just consider a trial of iron replacement and see how we go. Macrocytic anemia is again not uncommonly seen. Typically, alcohol abuse, megaloblastic anemia from a deficiency in vitamin B12 and/or folic acid, as well as accelerated erythropoiesis secondary to bleeding or hemolysis, and hyperthyroid. Medications, you probably can include that in that profile as well, with some of the chemotherapy agents, or methotrexate, azathioprine, phenytoin, I guess important one to consider. Liver dysfunction, as well as myelodysplasia. Iron function tests, we do them a lot, and as I said, they're sometimes not as specific as we'd like them to be. The big ones to consider, obviously, the difference between iron deficiency and anemia of chronic disease, and the big way for to tell the difference between them is looking at the ferritin or the total iron binding capacity. But again, it can lack sensitivity some of these cases, but of course it is worth looking at this profile just to make sure we're not dealing with an iron deficiency that may respond to some iron replacement. So hemolysis is a cause of anemia where we're going to get increased red cell destruction, and it's going to exceed the marrow's capacity to compensate. Typical findings are going to include a reduced haptoglobin, a raised lactate dehydrogenase or LDH, and raised unconjugated bilirubin. But these are not fully sensitive or specific. I mean, I think if they're going to give it to you in the exam, it's going to be sort of more classical presentation. But I think it's worth remembering in real life it sometimes doesn't have the exact sensitivity or specificity we'd like it to. A positive direct Coombs test may suggest autoimmune hemolysis, but this can be positive in other circumstances, such as following therapeutic immunoglobulin infusion, or stem cell or organ transplantation, or alloimmunization following recent blood transfusion. So clinical context is important. Hemolysis can be intravascular or extravascular. Acute intravascular hemolysis can be life-threatening, and this is why we're going to, may require renal or cardiovascular support, and that's why we can see it in the ICU. Patients may develop chills, rigors, back pain, dyspnea, hypotension, tachycardia, dark urine, oliguria, and shock. The blood film is typically going to show red cell fragments that again we'll discuss later. And LDH is going to be markedly elevated compared with extravascular hemolysis. Urine and plasma both can become very dark red or brown due to the presence of free hemoglobin. And this is where some of the hemoglobin, this is caused because some of the hemoglobin is taken up by renal cells and iron and stored as hemosiderin. and this is subsequently shed into the urine, where it can be detected for about 1 to 2 weeks after the onset of hemolysis. In patients where severe intravascular hemolysis is a major presenting feature, we've got to consider, have there been any recent blood transfusions? Are we dealing with an ABO mismatch or bacterial contamination? Has there been any recent foreign travel or a splenectomy? And investigating with thick and thin blood films is important, maybe antigen testing. One they love in the exams is obviously going to be Clostridium perfringens sepsis. I mean, this is the high end of the spectrum. This is where we're getting fulminant intravascular hemolysis occurring within hours, and it's caused by the alpha toxin that's released. And it actually only happens about 10% of cases, but when it does, it's associated with shock, multi-organ dysfunction, and mortalities, 80% and above. Risk factors will include diabetes, malignancy, or a following abdominal surgery, and the primary focus is usually hepatobiliary, GI, uterine, and infection with a traumatic or gas gangrene can also sort of lead to this form of sepsis. You'll see typical features on the blood film will be the spherocytes or depigmented red cells, and the tissue and blood cultures are going to confirm the diagnosis basically. Treatment is early high-dose antibiotics, something like penicillin or clindamycin, and of course source control with decent surgical debridement of the tissue. Review medications. Consider sort of perioperative antibiotics, where you can get some kind of immune hemolytic anemia, such as from like 2nd or 3rd generation cephalosporins or diclofenac. Overdose or inhaled a toxic substance. You can get methemoglobinemia with denatured hemoglobin that can occur if with things like nitrites or inhaled amyl nitrate or something. Again, not that common. Exposure to the cold with paroxysmal cold, hemoglobinuria, or some of the other rare causes like the glucose 6-phosphate dehydrogenase deficiency, and there's going to probably be a familial history they'll describe. Or paroxysmal nocturnal hemoglobinuria, PNH, which is an acquired stem cell disorder that renders blood cells susceptible to complement-mediated injury. Again, these are the rarer things, and if you're looking for the gold prize, put them on the exam, obviously. Intravascular hemolysis may not be the major clinical feature of the disorder, and I guess it's not always fulminant. And examples can include renal failure, where you're going to get red cell fragments maybe present due to the uremia or complications of hemodialysis. Extracorporeal circuits, or indwelling TIPS procedures or something. Severe burns, drowning, DIC, periprosthetic heart valve leaks. Intensive exercise has been shown to cause it. Oxygen drugs, oxygen drugs like dapsone. Or Wilson's disease, they can present with liver and neurological disease. So those are some of the other things about the non-fulminant intravascular hemolysis that is mainly extravascular. Can be caused by intrinsic or extrinsic factors. The intrinsic causes are mainly inherited conditions giving rise to this sort of chronic hemolytic state, and then you can get this decompensated anemia that can occur with additional stresses, infection or iron deficiency or pregnancy. These are on the sort of more rare end of the spectrums. I guess from hemoglobin disorders, you have things like thalassemia, red cell membrane defects, something like hereditary spherocytosis, red cell enzyme deficiencies, looking at things like pyruvate kinase deficiencies. What's probably a more common cause of the extravascular hemolysis that we'd see in the ICU would be things which are the extrinsic causes, such as liver disease, where you can get an effect on the red cell membrane, splenomegaly leading to red cell sequestration and destruction, some of the immune-mediated processes where, for instance, you can have a delayed hemolytic transfusion reaction that can occur 1 to 2 weeks after a transfusion, or immune hemolysis by solid organ or bone marrow transplantation, for example. So I guess in conclusion about anemia, it's common, it's multifactorial, has to be taken in clinical context, which is going to help. Classification according to the MCV can be useful. It's probably the place I start at. And anemia is most often going to be normocytic and contributed to by blood loss, hemodilution, impaired EPO release, but you've got to also consider some of the more weird and wonderful things with hemolysis and hemoglobinopathies and tissue microangiopathies and things like that in the ICU. So leukopenia, so low white cell counts, and this is typically defined as a total white cell count below the lower limit of normal, which is less than 3.5, and we're seeing this in maybe 7% of ICU patients. We know that it's associated with mortality, and it can be the result of a reduction in any of the major subtypes, neutrophils, lymphocytes, monocytes, eosinophils, or basophils. I think most frequently it's the neutrophils and or the lymphocytes, and we'll consider each of these in turn. In the ICU setting, leukopenia and neutropenia is usually secondary and most commonly due to infection or drugs. I guess a primary hematological problem such as leukemia or another malignancy, it's possible, but it rarely develops in the ICU, and I don't think it's the kind of thing that's going to come up in the exam. In terms of examining it or for looking at causes of the leukopenia or the neutropenia, it's important to look at the temporal relationship and try and see whether it's isolated leukopenia or a neutropenia, or is it associated with other cytopenias, so that if you have a pancytopenia, for example, that's going to suggest the presence of bone marrow failure from any cause, including drugs, I guess, or hypersplenism. In terms of the pathogenesis, it's going to be the usual stuff where you have decreased production or increased destruction. In terms of the white cells in particular, you can have increased margination or aggregation or splenic pooling that can occur. So particularly in things like infection with influenza or CMV or bacterial causes like tuberculosis or something, that's where you're going to get the neutropenia in particular developing because of margination and sequestration in the spleen and in the lungs. Something like HIV can be associated with antibody formation, and that can lead to aggregation and increased destruction, as well as bone marrow suppression and cytokine-mediated destruction. Immunological causes such as vasculitis or SLE can lead to neutropenia or leukopenia through antibody-mediated destruction, and disease control is often going to lead to resolution of the leukopenia. Obviously, there are sort of some of the nutritional deficiencies with vitamin B12 and or folate deficiencies that can be associated with that as well. Neutropenia is classically graded into mild, moderate, or severe, and obviously the more severe, the higher the mortality, and particularly if you've got persistent and severe neutropenia, that's going to be leading to the complications. Lymphopenia can be a pre-existing problem, or it can develop during the ICU stay. The approach to lymphopenia is the same as to neutropenia in terms of reviewing the history and previous results to see if the longevity of it. Long-standing lymphopenia is most likely a result of chronic viral infections like HIV or marrow deficiency, whereas acute viral infections can often lead to a more acute deterioration in the lymphopenia. And typical viruses we're talking about are things like EBV and CMV. If you have got lymphopenia, you are susceptible to infections, and we have empiric therapy in New South Wales, which would include tazocin and aminoglycosides, which is what we'd use, and you need to get on top of that fast. So I guess with all of these leukopenias, it's important to remember that these patients are susceptible to infection, and they can progress more rapidly into severe sepsis and septic shock than those with normal white cell counts. Remember that you manage them in a side room. It's often forget to write that down in the exam, and there'll probably be a point in itself. And instituting urgent treatment if required, in particular source control. Thrombocytopenia is extremely common in the ICU, and it's going to happen anywhere between 50 to 60% of patients. Classically surgical, more than medical patients get thrombocytopenia, and maybe 50% of those with thrombocytopenia are going to have it on arrival into the ICU, and the next 50 are going to develop it within about 4 days. It does hold prognostic significance, and it can be a marker of severity of illness. Often the sort of classical things that you hear about in the outpatients, including purpura, petechiae, and bleeding, they're often absent in the ICU patient with thrombocytopenia. And if we're getting levels less than 50, that's when, but if we get levels less than 50, we know that we've got a significant risk of bleeding increase 4 to 5 times. And spontaneous intracranial hemorrhage, which we're particularly worried about, is most commonly seen when the platelet count is less than 10. If we do get platelet aggregation, which can associate in organs, and it's been described as a contributory factor to multi-organ failure and increased risk of thrombosis. And we're also seeing that we also know that platelets are integral constituents of the mechanisms necessary for maintenance of vascular integrity. Hence, in cases of thrombocytopenia, there's increased capillary leakage and vascular edema. And that's evident in things like disease processes like adult respiratory distress syndrome. In the way to try and determine the causes of thrombocytopenia, for practical purposes, I kind of split it up into decreased production, increased destruction, increased aggregation, dilutional, and sequestration. Sorry about some of the typos there. Decreased platelet production essentially comes from bone marrow suppression leading to thrombocytopenia, and it can occur in response to drugs, which I guess is one of the most common cause, where we're getting myelosuppression, such as from chemotherapy agents, or we can have immune-mediated mechanisms like heparin, and antibiotics, meropenem and penicillin derivatives. They can often be causes of it, as well as PPI and diuretics. Which are some of the uncommon causes. To try and figure out if it's drugs or not, there's a temporal relationship you have to look into, and if you cease the drugs and you see the platelet count improve, it gives you a diagnosis. Infections can be viral or bacterial. The viral infections such as EBV and EBV, CMV, as well as the more chronic infections, we're often getting thrombocytopenia as a consequence of what's known as molecular mimicry, where the virus resides inside a protective barrier created by the platelets, and these then become immunogenic and destroyed by the body's defense mechanisms. Bacterial and fungal infections are often associated with platelet aggregation. Drugs such as alcohol can affect platelets through the development of liver cirrhosis, nutritional deficiencies with B12 and folate. They can exacerbate the platelet production. They can exacerbate the decrease in platelet production. Excuse me. And finally, of course, bone marrow disorders like leukemia and lymphoma and metastases. They're not common, but of course they're going to affect the bone marrow production. Thrombocytopenia due to increased platelet destruction can occur through immune or non-immune mechanisms. Immune-mediated thrombocytopenia from antibody production against platelets in response to, again, viral infections or drugs like heparin, or it can follow things like transfusion reactions as well. Non-immune mechanisms include the extracorporeal circuits that we're using for cardiopulmonary bypass or hemofiltration or intra-aortic balloon pumps, for example, as well as from the vasculitides, where immune-mediated as well can be the cause in this, of course. Increased platelet aggregation is probably the main cause of thrombocytopenia and bacterial sepsis. The platelets can aggregate with each other and also with other cells like monocytes or neutrophils. That leads to a decreased number in the total platelet cells that are migrating around the body. There's also increased binding of these platelets to each other as well as to the activated endothelium, and this means you can get platelet sequestration as well as destruction in the microvessels. And this is what we can see with increased platelet consumption that can then occur in things like DIC or the thrombotic microangiopathic disorders like TTP or HUS, and HELP syndrome in pregnant women, which is the one that's characterized by hemolysis, elevated liver enzymes, and low platelets, as well as massive P. And recently, acute drop in platelet count has been described as a phenomenon in thrombotic storm, where widespread thrombosis occurs in different organs and leads to thrombocytopenia due to increased consumption. Dilutional thrombocytopenia can occur if you're giving large volumes of crystalloid or colloid infusions. Platelet sequestration secondary to splenomegaly from cirrhosis or congestive heart failure, portal hypertension, or infection and myeloproliferative disorders. Approximately 1/3 of the total platelet mass is sequestered in the spleen normally, so that if you get splenomegaly from any of these causes, this can increase up to 90%. Interestingly, these patients are less likely to bleed as their platelets are able to be enter the circulation in response to a stimulus, but they also have a normal lifespan. So that's the one good thing at least. In terms of the diagnostic approach, similar to as we've discussed before, you've got to consider your presenting complaint. Try and obtain an accurate sort of history and time span of when the decrease occurred. Drug history is obviously important, including things like heparin to consider hits, as well as transfusions that have been given. Look for a clinical examination for any signs of bleeding or microthrombus formation, as well as splenomegaly as discussed. In terms of the investigations, look at previous lab results to determine the rate of thrombocytopenia development and see if it's happened over, I guess 5 to 7 days would be more in keeping with a decreased platelet production or a consumption approach, while I guess a more abrupt sort of platelet count within 2 weeks of transfusion or something, or a drug points towards an immunological cause maybe. Blood film, as we'll discuss later, is important to have a look at. If you have platelets clumping together, that's going to indicate that the thrombocytopenia may be spurious, or it should be repeated in a heparin or citrate-containing blood collection tube. If you have schistocytes, that might indicate a microangiopathic process. If you have a leukoerythroblastic blood film with teardrop cells or nucleated red blood cells or immature granulocyte cells, that may suggest an underlying bone marrow disorder. Microcytosis, we're looking for that could be associated with vitamin B12 deficiencies, hypothyroidism, alcohol toxicity. Malaria, maybe another one you can add into there to see it on the blood film. Clotting abnormalities may suggest sepsis or DIC. You can look at liver function tests for cirrhosis. Hemolysis will be associated with thrombocytopenia, but you'd have also raised lactate dehydrogenase, retics, bilirubin, haptoglobin, as we discussed. Consider HIT screens, vasculitic screens, consider nutritional deficiencies with B12, and of course bacterial and viral screens to consider infection being a cause. In terms of the management, the general principle is to treat the underlying cause. Platelet transfusions can be considered, but generally not less the platelet count is less than 50 with risks of bleeding. I generally will give platelets if they're below 10. You just give them a platelets automatically. Below 20 if the patient is already septic or significantly ill, and if we're above 30 if the patient is bleeding. So high blood counts, we'll just consider thrombocytosis, leukocytosis, and polycythemia. So that's raised platelets, raised white cells, or raised red cells. Thrombocytosis is defined as a platelet count greater than 450, and although it's uncommon in the hospital, we can see it in up to 1 in 5 of our patients at some stage during their time in ICU. Differential diagnosis includes primary or secondary or reactive causes. Primary causes are most commonly sort of myeloproliferative neoplasms. You can get the rare inherited or genetic problems. And patients, they're going to have splenomegaly, weight loss, night sweats, fatigue, loss of appetite, and those kind of things, as well as other sort of blood count abnormalities like a raised white cell count and a raised hematocrit or anemia. Bleeding risk, interestingly enough, is also increased in these disorders, particularly if you're getting platelet counts greater than 1,000, and that's mainly attributed to acquired von Willebrand's disease or platelet dysfunction that also occurs in these cases. Leukocytosis is defined as white cell counts greater than 2 standard deviations above the mean, so that's about 11. It's usually it's on most sort of prognostic scoring systems. That's because it's a marker of obviously poor outcome. The reason for leukocytosis is in most cases readily apparent, and treatment is again just treatment of the underlying disorders. You get a leukomoid reaction where you're getting marked elevations of the white cell count, typically greater than 50, and this is associated often with sort of a left shift in bacterial infections or severe hemorrhage, TB, or sort of paraneoplastic reactions to solid organ malignancies. And if it is due to a paraneoplastic reaction, typically having white cell counts above 50, and this is a sign of a huge tumour burden and poor prognosis. It's important that if you do see these raised white cell counts, that you differentiate it from leukemia. A leukomoid reaction, the leukocytes are predominantly more mature cells, and neutrophils typically have reactive changes, and there may be sort of a reactive thrombocytosis, whereas in things like CML, where you've got white cell counts which may up like 500, you're going to have a massive splenomegaly. There's going to be a predominance of myelocytes and basophils, and if you've got sort of hypergranular neutrophils with a predominance of blast cells and rods in the blood film, that's obviously going to favour leukemia, and we'll discuss a little bit later with the blood film. Different parts of the white blood cell system can be raised, and they're associated with different things. A mild sort of persistent neutrophilia can just be a normal variant, but if we're seeing very high levels, that can be a primary cause. Is obviously sort of something like acute myeloid leukemia or CML. Secondary causes would include, the secondary causes are probably more common in the critically ill patient, and they're often due to infection or inflammation, and they're usually multifactorial. You're going to get these reactive changes, and again, looking at the blood film, you're going to see what's known as Dole bodies or cytoplasmic vacuoles with toxic granulation. And that's often a sign of infection or inflammation, and that's typically associated with this, what it describes as a left shift in the blood film. Lymphocytosis, it's going to be higher in neonates and young children as part of the normal finding, and acute infective lymphocytosis due to things like a viral infection with sort of mononucleosis, infectious mononucleosis, and you can look for that on a monospot test or something. Other things like Coxsackie can cause it, smoking, after splenectomy, things like that. And you're typically going to be seeing large atypical lymphocytes on the blood film. Eosinophilia, this can occur in the recovery phase of infection. If you're seeing marked eosinophilia, levels greater than 5, this requires assessment for end organ damage, and I guess you've got to be considering parasitic infections that could potentially be associated with that, as well as connective tissue disorders, some of the vasculitis, as well as looking at drug reactions as well, non-steroidals, cephalosporins, phenytoin, they've been implicated in the process. A monocytosis, I guess, is more associated with problems like, from the secondary side of things, with malignancy and chronic infection, as well as rheumatoid arthritis and SLE. Polycythemia is a sign of when you've got a hematocrit greater than 0.6, and it's going to be influenced by the plasma volume as well as the red cell mass. But an absolute polycythemia can be proven when the blood volume studies indicate a red cell mass that's greater than 25% above the mean predicted value, is essentially what we look at. Polycythemia is highly likely to be present when you've got a hematocrit greater than about 0.6. If you do patients who do have polycythemia, they are at risk of thromboembolic complications through hyperviscosity, essentially, and classically the presentation can be with blurred vision, headache, lethargy, or weakness. The causes can be relative, such as when you've got sort of dehydration or smoking, hypertension, or shock, unless you've got a decreased plasma volume, or they can be absolute, in which case we're looking at primary or secondary causes. Primary causes include polycythemia vera, and secondary causes include congenital or acquired defects. The congenital ones, like reduced 2,3 DPG mutase problems, they're rare, and the acquired ones are the ones that we've got to be looking out for. So they're the cyanotic heart diseases, the chronic lung disease, or smoking, high altitude. An important one to consider is erythropoietin-producing lesions such as renal cysts, any kind of renal artery stenosis, or renal adenomas. Uterine fibroids is a classic one to think of, as well as hepatic lesions like carcinoma. Let's turn our attention now to the clotting factors and abnormal clotting. So prothrombin time, or activated partial thromboplastin time, the PT and the APTT, these are the most commonly used screening tests for coagulation. So these tests were designed to assess the coagulation system based on the extrinsic and intrinsic pathway. And I guess for this reason, an abnormality in these tests doesn't always translate to clinical bleeding. It just means that there's potentially an abnormality in the clotting cascade. And although they're useful in ruling out most causes of bleeding disorders, they're not perfect, so they can't exclude some mild bleeding disorders such as rare diseases like factor 13 disorders, and that's because they're assessing that intrinsic and extrinsic pathway. The prothrombin time is analysis of the extrinsic system. It's called the extrinsic system because it's tissue factor is the initiating factor, and that was considered extrinsic to the body. Prothrombin time is going to be affected by factor 2, 5, 7 and 10, as well as by decreased levels of fibrinogen. Prolonged PT in the ICU is most commonly due to vitamin K deficiency from whatever cause. The rest of these causes are in decreasing order of frequency and include liver disease, where prothrombin time is often the first abnormality before APTT. DIC, decrease in fibrinogen. High doses of heparin, often prothrombin time is insensitive to unfractionated heparin because the prothrombin time reagent includes a heparin neutralization agent. So often it's only higher doses of heparin that affect it. and then obviously factor 7, 2, 5 and 10 deficiencies can affect it as well. Activated partial thromboplastin time, or APTT, is the analysis of the intrinsic system, and the ICU heparin is going to be the most common cause of this. We've also got other causes in or a decreasing order of frequency. If you're concerned about the heparin, we can also look at the thrombin time, which is the time that plasma takes to clot after adding a solution of thrombin to the plasma. So we know that thrombin time is going to be prolonged by heparin, but not by deficiency of clotting factors. So that can help you analyze that. So other causes include lupus anticoagulant, which is notorious for causing an abnormal APTT, but it's usually of minor significance because patients don't seem to have a significant increased risk of bleeding. Liver disease, DIC, decrease in fibrinogen, massive transfusion, clotting factors deficiency including 8, 9, 11 and 12, as well as deficiencies of factors of 2, 5 and 10, and as from the previous slide we know that we're going to get abnormal prothrombin times as well. Here's a good table just to try and memorize, just to try and help you. I mean, again, it's this classic exam question where they'll give you the results and ask you for possible causes. It's worth remembering because, as I say, they love asking it. The most common ones they're going to be coming up with, I would imagine, would be the vitamin K deficiencies, as well as DIC and acute liver disease. So INR, the International Normalized Ratio, this was developed because prothrombin time is based on this tissue thromboplastin reagents, and the problem was that depending where you got that from the tissue of origin, you're going to have varying clotting times between all the different places that it uses. So the INR was developed mainly to sort of standardise the widespread use of warfarin, essentially. So warfarin exerts anticoagulation effect by inhibiting the function of vitamin K dependent coagulation factors. So again, worth remembering this, because they love asking this, is factor 2, 7, 9 and 10. The World Health Organization wanted a reference standard for thromboplastin. So that's where the INR came from. So I guess in this context, it's really important to remember that the INRs are not reliable between laboratories for any other clinical conditions, which are normally associated with a prolonged prothrombin time, such as DIC or liver disease, because in those situations you've got to use prothrombin time rather than INR. And this is because INR standardization is based on plasma from patients anticoagulated with warfarin or similar agents. While we're on the clotting profile, I thought it might be worth at least just bringing up TEG, or the thromboelastogram, which is an assessment of global hemostatic function. It's probably more used in the anaesthetic terms because they like having sort of near-patient point-of-care sort of coagulation tests. The way it does it assesses clot formation in a sort of simulated sluggish venous flow state, and essentially we just put a tiny sort of bit of whole blood into this pre-warmed cup, and it's oscillated at an angle sort of with a slow rotation, and you have this plastic pin that's in there, and you get a blood clot that forms behind this plastic pin, and a computer would analyze the signal that gets produced by it. And essentially you get different things that you can look at, including sort of the enzymatic R time, which is looking at the clotting time, as well as the clot kinetics, which is how fast the blood clot forms, which is considered sort of an assessment of fibrinogen, as well as platelet activation. And then finally we talk about fibrinolysis, which is the tail part, which looks at the clot strength and the platelet function. I'm not sure whether you have to remember all of this on the it's worth remembering all of this from the table, but it's just worth remembering that R time, which is that sort of first initial part, is an idea of sort of that initial sort of fibrin formation rate, and that's obviously going to be dependent on your clotting factors and inhibitor activity. The K time and the alpha angle, which is how that blood clot then forms, that blood clot then forms up, and that shows you how well that fibrin sort of builds up and cross-links, and that's going to be dependent on fibrinogen and platelets, as well as sort of the intrinsic clotting factors. And that speed of clot formation is going to be affected by things like thrombocytopenia and low fibrinogen levels. We look at the MA, which is the maximal amplitude, and this is dependent on the strength of the fibrin clot, which is going to be assessed by platelet numbers as well as the fibrin function and formation. And then we can look at the CLI and the A60, which are estimates of how that sort of the clot integrity lyses and how we get sort of clot retraction that forms. And this picture essentially shows some of the different kind of patterns that you can see on the TEG system, and it's worth remembering that you've got sort of the parts that are what a normal trace looks like, as well as something like a haemophilia or something that's got this longer R time, or a thrombocytopenia where you don't have such great platelet function, so that's a K time and alpha angle is reduced. If you look at something like fibrinolysis, you have the tail drops off faster than normal, or if you're hypercoagulable, you're going to have this shorter R time, and you're going to have this increased maximal activity. It hasn't come up a lot in the exams, but I thought it might be worth mentioning. So the blood film is the next thing to consider. I find these hard to remember. I've got to be honest. I've tried to make up various tables that might help put it into a pictorial format. There's no other way, I think, than just rote learning these, unless you're looking at blood films all the time and you're a haematologist. So I've got, there are many different things to try and remember. I've just got the greatest hits, I think, here, and these are the ones that I think come up the most in the exam. So I've got sort of 3 tables. And again, I've downloaded all these pictures from the internet just to try and help you remember what they look like, and maybe that will help remember the associated disorders. So the blood film, the acanthocytes, these are cells that have spicules and they look irregular, and they're associated with liver disease, uremia, hyposplenism, or hypothyroid disorders. Anisocytosis or poikilocytosis, that means just essential variable in size and shape to the red blood cells, and they're associated with hematinic iron deficiencies, hematological disorders, thalassemia. Schistocytes, that's a really common one to be talking about, obviously in the hemolysis setting. This is a red blood cell fragment, and that's going to come across from hemolysis from microangiopathic processes, or malaria, or ABO mismatch. Hal-Joel bodies, again, not seen in the exams a little bit for people who've had splenectomies done. Also associated with megaloblastic anemia or leukemias, and you just get these little dots that stay in the red blood cells, which are remnants of nuclear proteins. Target cells are seen as sort of where you get this central area of dense staining, and that gives you this, this bullseye picture. And I try and remember those because target cells, it sounds like you've got a thing on your, it sounds like you've got a bullseye on your back, and that can be associated with trauma, and that's where you get the splenectomy. That's how I remember it anyway. Chronic liver disease, sickle cell, thalassemia, as well as post-splenectomy patients. Spherocytes, associated with hemolytic conditions, essentially. That's where you get this loss of the cell membranes, loss of the membrane structure, and you get small cells which they don't have the classic sort of central pallor of a red blood cell. Stomatocytes have this linear slit, or this mouth-like structure, and you often see that in liver disease, alcohol excess, or inherited hemolytic conditions. And the last one from the red blood cell blood film, looking at the basophilic stippling, and that's where you have these multiple sort of small RNA deposits, and you get this speckled appearance, and that's seen with things like thalassemia or lead poisoning, as well as megaloblastic anemia and myelofibrosis. And just a few on the white blood cell line. So we often talk about left shift, and that essentially just means that you have immature white cells. And that's most commonly caused by infection in the ICU, but you've also maybe considered pregnancy and growth factor administration, but infection until proven otherwise, I think. Right shift is associated with hypersegmented polymorphs. That's more seen with uremia, chronic liver disease, or megaloblastic anemia. Our rods, I hope I'm saying that right, this is where you get these kind of rod-like structures in blast cells, and that's indicative of acute myeloid leukemia. And as we mentioned earlier on, if you get toxic granulation and Dole bodies, which is associated with infection or inflammation, and that's where you get this sort of neutrophil cytoplasm granulation and vacuolation. So let's finish up this talk with talking about a couple of the greatest hits in the exams, which are essentially the emergencies, or some of the emergencies in the haematology world. The ones that they love talking about in the exam, which essentially are just ones that you just can't miss in the ICU, are the heparin-induced thrombocytopenia, or HIT, DIC, or disseminated intravascular coagulopathy, as well as the thrombotic microangiopathies, or the TMAs, and that is basically a spectrum of disorders which includes TTP as well as HUS. So HITs, or heparin-induced thrombocytopenia, there are typically two types that are described. You've got type 1, which is the non-immune, which is certainly more common. It's also known as heparin-associated thrombocytopenia. It's where you see this drop in the platelet count by about 30%. It's certainly more common than the immune-mediated coagulopathy of heparin-induced thrombocytopenia, and it's less relevant essentially. So it's worth looking into, and it's almost a diagnosis of exclusion after you've ruled out all the rest of them. The main one that we're talking about with HITs is the type 2, the immune-mediated coagulopathy, which is where you get this immune-mediated coagulopathy that can occur in critically ill patients, and essentially happens after you get heparin exposure. What happens is you get antibodies are developed, which occur as a complex of heparin and platelet factor 4, which is a basic protein that's stored in the alpha granules of platelets. And if you get platelet activation, you get IgG antibodies. They get formed against these complexes of heparin and PF4. And the activated platelets generate microparticles. They activate other cells, including endothelial cells, which express tissue factor, and you get this procoagulant state. And that's why you're going to get these thrombotic complications in about 40 to 80%. So it's not hugely common to get this type of reaction. It's about maybe 1% of patients receiving unfractionated heparin, and less if you're receiving low molecular weight heparin, like clexane. But I think in the ICU the incidences are high. I've seen a good few cases of these, and so I think the incidence may be higher than that, particularly if you're in cardiothoracic centres. In terms of the lab test to try and investigate for this, it can be difficult to try and pick this up, and that's because with some of the tests that take a short amount of time to come back, and they lack sensitivity. The basic way of testing for it in the lab is including antigen antibody assays and also using functional platelet activation assays. And the antigen antibody assays, they come back a lot quicker than the functional platelet activation assays. So the most commonly used one that we have a look at is sort of commercial ELISA, or ELISA, and they detect the IgG or IgM or IgA antibodies. And so they're not going to be specific for HITs. The important thing, rather than just looking at whether you've got a positive or negative report, is to look at what's known as the optical density. And essentially the higher the optical density, the higher the likelihood that the more sensitive tests, which are some of the functional platelet activation assays, will be positive. And typically if you're looking at optical density greater than 0.5, that's where you're likely going to get a positive reaction on the SRA, or the serotonin release assay. The functional tests, which include this serotonin release assay as well as the heparin-induced platelet activation test, these tests are, they detect heparin-dependent platelet activating antibodies, so they have a higher sensitivity, and these are the gold standard essentially. But not every centre does it. They have to be sent away. Hence, certainly in hospitals I've worked at, it takes a while for these ones to come back. In terms of trying to make the diagnosis of heparin-induced, in terms of heparin-induced thrombocytopenia, it's all about trying to put it into clinical context and to trying to improve the sensitivity and specificity as quickly as possible. And that's where we've got this sort of pre-test probability using the 4Ts, which are looking at how quickly the thrombocytopenia falls, and if particularly if it falls by 50% very quickly, then that's worse than if it just falls by 30% or so. If that fall comes on less than 1 day, or it's compared to 4 days, that's obviously another sign that you're dealing with hits. If we're getting new thrombosis that's occurring, as well as horrific systemic reactions or necrosis, that's going to be more indicative of hits as opposed to if there's no thrombosis occurring. And of course we need to consider other causes of thrombocytopenia. And you can get this scoring system that was developed from this paper that you can see the reference below, and the higher the number, the increase the likelihood of heparin-induced thrombocytopenia. In terms of how to treat heparin-induced thrombocytopenia, obviously you've got to discontinue the heparin straight away and start non-heparin alternative anticoagulants, and that's going to include sort of direct thrombin inhibitors like argatroban or leperudin or bivalirudin. These direct thrombin inhibitors, they don't resemble heparin. They're not going to cross-react with the heparin platelet factor 4 antibodies, and they don't promote heparin-induced thrombocytopenia. So dinapronide was one of the first ones that's heparinoid that had minimal cross-reactivity, but it's not widely available, and so you can have other things like fondaparinux, which is selective factor 10A inhibitor. But it does have a really long half-life, and you kind of got to watch it, especially if there's renal failure. So the general rule of thumb that they recommend, certainly from some of the UK guidelines, if you've got a hit with no thrombus, then look at argatropan. Watch for those in liver failure. If you've got hits with thrombus, argatroban or leperudin, and I think that's from leeches actually, some of that stuff, and consider bivalirudin as well. A very common syndrome that you're going to come across at some stage in ICU time is obviously DIC. It's worth remembering that sort of have it in the same ballpark as thinking of it a bit like ARDS, in that it's a syndrome, not a disease. And I think that's important, particularly when it comes to treatment of it, because treatment is essentially, you've got to sort out what's causing the DIC, because the DIC is not going to get better just by replacing factors. So it's a syndrome, not a disease. DIC is an over-exaggerated physiological response, and I think this definition provided by the International Society on Thrombosis and Hemostasis gives a really nice summary of it. So it's an acquired syndrome characterized by the intravascular activation of coagulation with loss of localization arising from different causes. It can originate from and cause damage to the microvascula, which, if sufficiently severe, can produce organ dysfunction. And if you've seen this, you will know exactly what I mean by organ dysfunction. In terms of the pathophysiology, it's basically you're getting unregulated and excessive generation of thrombin, and you get this aggressive, accelerated thrombosis that can then occur. And the inciting insult, like sort of sepsis, if it's persistent and severe, means that this is driven on and on and on. It can become extremely excessive. And you can get this consumption of all the coagulopathy factors, and so you get this almost this thrombin-orchestrated fibrinolytic pathway, which is trialing frantically to deal with excess fibrin formation, and so it's generating all these fibrin degradation products through plasmin, and you get this consumptive coagulopathy. So you're seeing both bleeding occurring as well as thrombotic manifestations. And renal dysfunction has been suggested in some trials to be one of the more common abnormalities that occur in terms of initial organ dysfunction. But of course, if you're not dealing with this properly, then it can develop on and affect everything from the cardiovascular, leading to shock, as well as GIT manifestations and the rest. The diagnosis is made through, the diagnosis should be considered in any patient who has this progressive thrombocytopenia, particularly if you're seeing worsening prothrombin times, APTT, decreasing fibrinogen levels, or increasing D-dimer levels. You get various scoring systems that can be looked at, such as the International Society of Thrombosis and Hemostasis have got a scoring system, as well as the Japanese Acute Medical Association, and you can look those up to see what they mean. I think the bottom line is to make sure that you consider this if you're seeing progressive thrombocytopenia. The problem is that looking at sort of the simple coagulation factors, they're not perfect. For example, you can have a fibrinogen reduction, but fibrinogen can also be increased initially, and then when you get in the DIC developing, it just brings the fibrinogen level down to normal. So you can get a normal fibrinogen level and DIC. Similarly, I guess you have normal PT and APTT may only be noted in maybe half of the patients initially. And you've got to remember also that prolonged PTD is very common from, you've got loads of different causes of vitamin K deficiency. And also, thrombocytopenia, this can occur in many, many different settings. But it's normally pretty devastating when it does occur, and associated multi-organ failure, and it's not one that needs to be missed. In terms of the differential diagnosis, includes sort of catastrophic antiphospholipid syndrome, which usually presents with sort of multi-system thrombosis in both big and small blood vessels. But the PT and APTT is normally normal in this condition. TTP, we're going to talk about in a little bit. This, maybe the thrombocytopenia is a bit more abrupt in this setting, and there's hemolytic anemia as well. And the blood film is going to back that up. Liver disease, I guess a serial worsening of the lab parameters may point towards a DIC. But a liver disease, I think, is particularly difficult to try and differentiate between DIC. Sepsis without DIC, thrombocytopenia can be caused by many different things, most common being infection. HITs, and then you can go on and assess it maybe with the predictive settings that we just talked about before, as well as systemic vasculitis, where you can get multi-organ failure with systematic vasculitis, but I guess having a low fibrinogen level maybe isn't characteristic in these states. As we said, DIC, the treatment is of the underlying disorder. You can provide transfusion support, but maybe that's only for patients who are bleeding or have extremely low sort of platelet levels. We're worried about blood clots, but these patients are also bleeding, but you've got to be looking out for blood clots. And in this regard, you can consider things like heparin in the unfractionated form. That's sort of historically used. In recent years, I guess we're trending more towards using low molecular weight heparin because it's got a bit more of a predictive pharmacokinetics and lesser bleeding risks maybe. Antithrombin therapy has been suggested, but that's mainly in clinical trials at the moment. Thrombomodulin makes sense. That's the endothelial surface cofactor, which when you have thrombin there, it's going to potentiate the activated protein C, which is the anticoagulant. And again, trials have suggested that's maybe a good one to use, as well as synthetic protease inhibitors. And again, I guess I'd be only using these in conjunction with the haematology consult. Finally, let's talk about the thrombotic microangiopathies. So this is a spectrum of disorders where you start getting thrombosis in the small blood vessels as well as thrombocytopenia. And you have this characteristic appearance on the blood film of a microangiopathic process with red cell fragmentation and polychromasia, which is the abnormally high number of red cells in the bloodstream. which have because they're prematurely released from the bone marrow during the blood formation. There are two major types: hemolytic uremic syndrome and thrombocytopenic purpura, or TTP. And the differential diagnosis can be tricky. It's got to be a clinical one, I think. And differential diagnosis is very similar to what we just discussed, including DIC, horrific sort of SLE autoimmune reactions, catastrophic antiphospholipid syndromes, as well as sort of malignancy and infections. TTP. So TTP results because of the deficiency in the von Willebrand's factor cleaving protease, which is called ADAMTS13. It's obviously got a genetic component, and there's no age limit, but typically you're going to see this disorder affecting females between about 30 and 40 years. The classic characteristics are described include thrombocytopenia, MAHA or microangiopathic hemolytic anemia, and clinical features relating to microvascular thrombosis, in particular neurological impairment and renal dysfunction. Although, of course, you can also get cardiovascular abnormalities and GIT abnormalities. So you can see infarctions, arrhythmias, etc. I guess this sort of classic pentad, they say it's rarely seen, but if they're going to give it to you in an exam, I bet you they give you all of the classic findings. In terms of laboratory features of TTP, we're going to be seeing signs of hemolysis with the red blood cell fragmentation, polychromasia, anemia, thrombocytopenia, raised reticulocyte counts, and a high LDH, which is often sort of abnormally high, and that's often because it's associated with tissue ischemia as well. The clotting profile is typically normal. You've got to diagnose this fast. It's a clinical diagnosis. It's got to be diagnosed and have a clinical suspicion of it, and the key to survival in it is plasma exchange. Mortality is nearly 100% without plasma exchange, and that's because plasma is the source of the missing or the dysfunctional enzyme, the ADAMTS13, and so plasma exchange allows delivery of large volumes of plasma and removes the causing factors. It's got to be started soon. If not, you can look at sort of high-dose plasma infusions as a holding measure, but essentially just got to get into plasma exchange fast. Immunosuppression can be added in to attain to a complete remission or prevent relapse, and you can look at PRED or pulsed intravenous methyl PRED or high-dose oral therapy. They're being used, as well as things like rituximab, the monoclonal antibody, or vincristine or cyclophosphamide. But that is obviously something that I'll be doing in conjunction with a hematologist. And supportive therapy while you're getting on there, that may be required while you've got rapid hemolysis. But you should be getting sort of folic acid supplementation with this. And unless you've got life-threatening hemorrhage, I wouldn't probably be doing transfusion because it can obviously lead to a disease exacerbation. So it's all about getting into plasma exchange. The hemolytic uremic syndrome, so at the other end of the spectrum, this is characterized by acute renal failure, thrombocytopenia, and MAHA. And we're typically going to see, in terms of the multi-organ dysfunction, renal microvasculature being affected, as we mentioned, as well as neurological impairments, heart and the GIT also being involved. You kind of got two main types of it: infection-induced HUS, which is called typical HUS, and atypical HUS, which is more prominent in sort of the adult ICU. The infection-induced HUS or typical HUS is seen in kids, and it's termed also D+, in D+ HUS, and this is all about Shiga or Shiga, like toxin-producing bacteria. The most common one they describe is the E. coli 0175. Essentially, you're going to have a kid who's going to have diarrhea-type illness, and 2 days to 2 weeks later, they're going to have the sudden deterioration. The diagnosis is usually pretty straightforward, based on the blood film and blood count and the serum creatinine and urinalysis. It's important to get the etiology right, and because the prognosis is pretty good, basically. The management's essentially supportive, and the vast majority of people will get through this, and they're going to have normal renal function at the end of it. Don't give antibiotics. They've been shown maybe don't improve outcomes, as well as steroids are not recommended, and there's no role for plasma therapy or anticoagulation in these kids either. The one that really they're going to be bringing up in the exam for the adult ICU exam is going to be the atypical HUS, which is children and young adults essentially. It's a rare disorder, but it's got a poor prognosis. It's got about a 1 in 4 mortality, and of the people who do get through, 50% of them are going to lose their renal function and need transplantation, which is frequently fraught with complications, or they're going to need to be on dialysis for the rest of their lives. The pathogenesis is essentially so uncontrolled complement activation, where you generate this inflammatory anaphylotoxin, the C5a, which then forms, we get the formation of the terminal complement membrane attack complex, or MAC, and that gets tissue damage. So you get this enormous sort of complement dysregulation. The management, as with TTP, is urgent plasma exchange, and the duration and frequency is determined by clinical response. So it moves the sort of the hyperfunctional complement factors and helps replace non-functioning complement regulators. We can also add in some monoclonal antibodies, eculizumab, which is also known as Soliris, and this has got this high affinity humanized monoclonal antibody in it. It binds and cleaves C5, preventing this formation of the sort of membrane attack complex, and so that sort of dampens down the response. It's important, if you are giving these complement inhibitors, they're at risk of increased microbial infection, particularly meningococcal infections, and that's why it's important to vaccinate these patients prior to treatment. So that's sort of the greatest hits for critical care haematology. I hope it was useful. These are the textbooks that I used and one of the websites. Highly recommend them, particularly the first one and the third one. And best of luck. See you later.